Hello. My name is Joanna Cohn. I'm the director of the Institute for Global Tobacco Control, and I want to welcome you all to our Innovations in Tobacco Control lecture series, the first one of 2015. For those of you here in person, I just want to let you make sure that you all sign in. There's a clipboard going around, and there will be lunch available just outside this room right afterwards, so make sure to pick that up. And then also during Q&A, if we don't have a microphone, Dien, if you can make sure to repeat the question, because we're going to be, we're recording it all. So thank you very much. Do we have a microphone? No. So I'll ask you to repeat the question. All right. So I'm so pleased to introduce Dien Anshari. He's an assistant professor in the Department of Health, Education, and Behavioral Sciences in the Faculty of Public Health at the University of Indonesia. He's obtained his Bachelor's of Science in Mass Communication and his Master of Science in Social Psychology, both from the University of Indonesia. And he's almost about to defend his doctoral research. He's a PhD candidate in the Department of Health Promotion, Education, and Behavior at the School of Public Health at the University of South Carolina. Dien is interested in health behavior and communication in different socio-cultural contexts. And the work that he's going to present today is very policy relevant. So he's going to focus on the impact of testimonials as part of graphic health warnings on cigarette packs. And currently, Indonesia does have graphic health warnings, but they're due to put in a new rotation, I guess, in the next year or so. And so this work, and he's been collaborating or involving the Ministry of Health at different phases of the project. So the intention is that this will be able to directly influence the next round of warnings in Indonesia. So I want to welcome Dien Anshari to give your lecture. So thanks so much.
All right, thank you. Thanks for coming. Thanks for the wonderful introduction. And I'm very pleased to be here to be able to share what we have learned and what we have found during the study that we conducted in Indonesia last year. And we are very grateful to have prominent researchers in pictorial health warnings labels. We have Dr. Jim Dresser, and we have Dr. Dave Hammond and Dr. Jessica Reid in our study team. And we are also very grateful to be part of the IGTC in doing this policy initiative research. And lastly, we are also very fortunate to be able to conduct this study just before the implementation of the first round of the pictorial warnings in Indonesia. So this is what I'm going to present. On the background session, I will just answering the question about why we conducted this study, and then on the method section, we're just going to explain on how we conducted this study. And then on the findings, I'm going to split the findings into two sessions. The first one will be on the answering which pictorial warnings were most effective among Indonesians. And then the second session will be answering the question of for whom were testimonial most effective. And that will be the main course of this presentation, I think. So before I begin to the next slide, I just want to ask you a question, and just please raise your hand if you're answering yes. How many of you have ever been to Indonesia? Oh, I know one Indonesian. Yeah. So it's very little. So probably I will give you a little more background about Indonesia throughout my presentation, so you will have more deep thought about what we found during our study. And let's just start with this smoking prevalence data. And this is a 2013 data. We see that in Indonesia we have the prevalence of smoking is 33.50%. And if we look at based on the gender, we have very wide differences, which for males is almost 2 out of 3 males in Indonesia are smokers. And for female, it's less likely to become a smoker. And when we lay out the data throughout the age groups, we can see that there is some kind of consolidated prevalence after reaching the 20 years old. And increasing is from the youth to the adult. So there will be one of the reasons why we conducted this study, and we focusing on adult, we only focusing for adult smoker, and for youth we focusing for both youth smokers and youth non-smokers. And let's look at the trends on smoking prevalence in Indonesia. We have a slightly decreased trend in the last 10 years from 35% to less than about 33.5%. And this is not good. In the last 10 years, we can say that we didn't do anything effective in reducing tobacco use in Indonesia. And if we look at a broader perspective, let's see from the 4 largest countries, and this is the data on 2012, and it's an age standardized data, so it's a little bit less than the previous data that I showed you earlier. We can see that China, as the biggest country, as the largest population in the world, the prevalence of smoking is 24%. India, the second largest country, the prevalence of smoking is 13%. And then USA, the third largest country, with smoking prevalence of 16%. And Indonesia, the 4th largest population, but has the highest smoking prevalence among other 4 countries. So, what do you think are the similarities between these 4 countries, if you can tell me about it? I did put some different highlights, like for China and India, I put a blue, and for USA, Indonesia, I put it black. What would be the differences between that? So for China and India, they already part of the FCTC. They are member of the FCTC. So we have something in common, Indonesia and USA. We are not member of FCTC. But how come USA has lesser smoking prevalence? And why Indonesia still have the highest smoking prevalence? We know that the USA is the origin of the tobacco. How come they have lesser prevalence than us? Let's take a look on the comparison between the tobacco control regulation in the USA and in Indonesia. As I said earlier, that we have something in common, and it's not something that we should be proud of. And we're not part of the FCTC member. In terms of the smoke-free laws, USA, right now, 37 out of 50 states have statewide smoke-free law. Well, in Indonesia, we have only 5 out of 33 provinces or states that has provincial law on the smoke. And not only that, we are also famous in the law and really not really well in doing law enforcement. So we are pretty lag behind the USA in terms of smoke-free laws. And in terms of tax ban, we can say that USA now have a very comprehensive tax ban, except for still having the advertisement in the stores. Other than that, they already banned the advertisement in billboard, print, even in TV. In Indonesia, we have limited tax ban. We still have billboard of cigarette advertisement around the country, and we still have print advertisement for cigarette packs, and then we also have TV commercials. Although it is limited only from 9 p.m. to 5 a.m., but still we still have this commercial in TVs. And then in terms of secession, in the US they have quit lines, they have websites, and also they introduced the use of LRTs. In Indonesia, we only have limited counseling. So far, if you ask any smokers who have helped to quit of smoking, they mostly only get advice to quit. They didn't get any other than that. And in terms of price, we can see the average price for Marlboro, a pack of Marlboro in the US is $6, while in Indonesia it's $1.23, $1.25. You can have a pack of Marlboro. And not only that, you can also get it in single. So it's easier maybe for kids to have to try the first cigarette when they buy it in single. So we only have one winning regulation for the United States. That is in the warning on the cigarette packs. You can see that USA, even it is, I think it's the first country to introduce the health warning labels on the cigarette packs. I think it's on the 1965, yeah, I think 65, almost 50 years. It's been 50 years. You should guys celebrate this 50th anniversary of health warning label, the tax only warning label. While we in Indonesia, we just have our first round of pictorial warning labels last year. So this is the only opportunity that we saw that we can really put much more effort in reducing tobacco use in Indonesia. So this is also part of our rationale to do this study in Indonesia. So if in the US we already have tax only warning labels since the 1960s, in Indonesia we just had it in 1999. And this historical perspective kind of give you insight that the changes of tax only warning regulation affected much more by the political decision, who is in power. So in 1999, if you are familiar with the socio-political issue in Indonesia, we have a reformation era in 1998. We pushed down the former regime of President Suharto, who has been in power for 32 years. And he succeeded by his vice president. And President Habibie the next year, in 1999, signed the first tax-only warning on the cigarette packs. And also in the 1999, President Habibie held the first presidential election during the Reformation era. Unfortunately, he didn't get elected, and it was President Abdurrahman Wahid who was in charge for the president. And the next year, the President Abdurrahman Wahid changed the regulation and give 5 more alternatives for the tax only, even better alternative. But President Abdurrahman Wahid didn't stay for quite long. In the next years, he was succeeded by his vice president. And in the 2003, President Megawati bring back the single tax-only warnings as the regulation for the health warning labels on the cigarette pack. Until 2009, we have a new health law that stating nicotine is addictive. It was under the administration of President Yudhoyono. And this statement stating that the nicotine is addictive is very crucial for us, for the tobacco control advocates, because this allows us to push stronger measures for controlling the tobacco in Indonesia. And then 3 years later, the President Yudhoyono signed the government regulation to implement the law. And starting 2012, there is a mandate to put pictorial warnings for cigarette packs, and this should be implemented by June 2014. And in 2014, we have 5 alternative pictorial warnings authorized for the first round, and each round will last for 2 years. So from 1999 to 2014, we have changed so much regulation in health warning labels, and we need only 15 years to change from the text only to the pictorial warnings. This is a little bit contrast with the United States, which almost 50 years and they still have law. And however, we don't want to be so proud with our first round pictorial warnings, because if we see in more details, we can look that we only have 40% of the pack and 40% of the bag of the cigarette packs. And we only have one statement as accompanying text for every image. And to be more precise in comparing the warning labels, let's take a look at the comparison between the Canadian warning labels and the Indonesian warning labels. As you may know, or maybe not, Canada is the first country to introduce the pictorial warning labels in 2001. And ever since, there have been changes in the implementation of pictorial warning labels, and this one, the latest regulation on the pictorial warning labels in Canada. So let's compare on the size. The Canadian have 75% on the front and 75% of the back on the back of the pack, while Indonesia only has 40% of the front and 40% on the back of the pack. And not only that, the Canadian also has inserts. And so if you look at this small document here, when you open the cigarette pack, you will see another like flyers stating about the health benefits and way to quit smoking. And if you take a look at the message, the Canadian this is what I can say as the supermarket of message. They have all the kind of message that we can expect in warning labels. They have efficacy messages. They have behavioral cues. They have information about the health risks. They have information about the health benefits as well. So they use these gain and loss framing strategies in their pictorial warnings. Well, in Indonesia, we only have information on the health risks. We only have one statement. This is also why we need to enhance. This is why we thought that maybe if we have another type of text, we will get a better, a more effective warning labels. In terms of the textile, Canadian have this testimonial. This one is from Barb Tarbox. She was a former actress who died at the age of 42, and she just said that this is what dying of lung cancer looks like. So this is a testimonial message, and they also include a didactic message under the testimonial message. While Indonesia, we only have didactic message. So if we compare between the two, we see that we still have so many limitations in terms of the pictorial warnings. We know we just implemented this last year, while Canada, not only the first, maybe because of Canada is the first to introduce, then why the Americans doesn't want to follow Canada? I don't think so. So, our study rationale is that we have very limited warning label study in Indonesia, in lower middle income country, and especially in Indonesia. Unlike in the US, we have, let me tell you this way. For our first round pictorial warnings regulation, it was only based on one study. So we did the study in 2007, and then we have the regulation on pictorial warning 7 years after that, based on this study. While in the US, we have seen so many published articles about the effectiveness of pictorial warnings, but still there is no regulation of pictorial warnings implemented until now. So because of this limited warning label study, we also want to provide recommendation and provide support for the decision that the Ministry of Health have done for the pictorial warning. Also, we need to confirm the effectiveness of pictorial warnings over the text-only warnings. I know that we have previous studies in different countries already confirm these findings, but we don't have one from lower middle income countries like Indonesia. And then we need scientific evidence to support the Ministry of Health. The first study that we conducted for the first round of the pictorial warning regulation was a polling survey asking whether they prefer to see pictorial warnings or text-only warnings on the cigarette packs. And then this polling was followed up with a focus group to see which types of warnings that they prefer to be used in the cigarette packs. So we need more evidence to support. We didn't have any evidence that can say that these pictorial warnings have scientific evidence as more superior than the text-only warnings. And another study rationale that we want to highlight here is that it's not only in Indonesia, we have a limited research in textiles. Although Canada already put the testimonial message on the warning labels, but so far I only found like 2 papers talking about the effect of testimonial message. And these two papers were not designed to test the design, to test the testimonial versus the text only in a controlled design. So I think it is our opportunity as well to do this kind of test. Based on the study rationale, we aim to first to assess the effectiveness of various types of pictorial warning labels and to provide recommendation for the next round, which warning that will be rated more effective by Indonesians. And then we aim to determine the effects of textiles on the perceived effectiveness and believability of the warning labels. All right, moving on to the next session, how we conducted this study. Let me start with the adaptation process. Because of we have prominent researchers in our study team, we were able to adapt the protocols that have been used in many countries. And we adapted in a way that this can applicable in Indonesian context. So for each warning image that has portrayal of people, we try to redevelop the image using Indonesian in the image. However, when we do this adaptation, we do it through a series of workshops, we get another lesson that the Ministry of Health said that we need to include real victims in our image. We didn't plan to do that, so it was time consuming, and they have a pretty strong rationale to push us to do that, because if they will use our image for the next round, they need to confirm that the model in the image are really victims of smuggling. So far, throughout, since the introduction of the 5 alternative warnings, they have been criticized with using people from different countries. So our first round regulation, we use image from Thailand. So all the people that portrayed into our pictorial warnings were Thailand. And they have been criticized for doing that. And then they push us to get the real victims, to get the real Indonesian. So after the workshop, we also conducted meetings, and we also building networks with hospitals to get the real victims of smoking. And it's not been an easy process, especially for special health topics like mouth cancers. I will tell you a story about the mouth cancer later. So this is what we decide in the image that we use. First, we select 8 health topics based on the applicability in Indonesian context. We took out aging because, as you know, aging is more relevant for females, and there are not many female smokers in Indonesia, so we don't think it is necessary. We took out emphysema, we took out gangrene and stroke because we couldn't find the similar terminology in Indonesian language. So we are afraid if we use the term gangrene, it will make people confused with what is gangrene actually. And we took out the pregnancy because of the saying we still keep the importance part, because we thought that more male smokers in Indonesia, and they will be prompt with the risk of getting impotence because of smoking. And after we have selected the health topics, then we go with the image, and then we select which image that should be redeveloped. And after getting the image, we go with the text. We get what would be the most applicable testimonial text for each image that we select. So for the didactic text, we basically just translate all that have been used throughout the world. But for the testimonial, we really ask, we do a small workshop to select the testimonial messages. The study sample, we have youth smokers and non-smokers, and we have adults only smokers. And we conduct a convenience sampling in markets, malls, restaurants, public parks. And we select Jakarta and Bogor district to collect to approach our respondent. And then we use a field experiment with the iPad-based program, so we can do some randomization for our respondents. So they will be randomized into different conditions. And this is just what we done for the procedure. First, after we get the respondent, we have a brief survey asking for the socio-demographic, smoking behavior, and self-efficacy. And then the first randomization was to randomize the respondent into either didactic or testimonial condition. And then we have the second randomization, which will assign them into one of 8 health topics. And then they have to rate, in each health topic we have 4 to 7 images. They have to rate each image. We have 11 rating questions. But for this study, we only use 4 or 5 for this presentation. After they rate the first block of topics, they will be randomized again to the second health topic. 1 out of 7 health topics, the rest have health topics. And then they have to rate again. And after that, we gave them a final question about reactants and self-efficacy. So we were able to do a self-efficacy question before and after the exposure. And this is just the show you sample of our textual condition. Basically, on the didactic we have, so for both we have the same image, but the textual message will be different. The didactic basically is just saying that smoking causes lung cancer, while the testimonial saying like, I'm suffering from lung cancer because of smoking. And then we also put the name of the victims of it. And for the image types, we have text only, no image. We have symbolic image, we have human suffering image. And then we have graphic or gruesome, external and internal. But for this presentation, I just combine these two into one gruesome image. And this is just the sample of image in one health topic. For this, it is lung cancer. So basically, they have to rate the similar number of image, similar kind of image, only different kind of textual style. And so as our independent variable, we have image types, which consists of graphic, personal suffering, symbolic, and then the text only. And then we also have text types, the didactic and the testimonial. And for the dependent, for the outcome variable, we have warning ratings, we have perceived effectiveness, which a combination of 4 questions. It is one of the question. And we have a believability question. Only one question for the believability rating. And in the future, we will do some moderating analysis from the exposure to cigarette advertising, because we still have the cigarette advertising law in Indonesia, and smoker identity and self-efficacy and the quit intention. All right, now we get to the first session of the findings. So this is the descriptive sample for us. As we can see that we have pretty much even distribution of the sample in each text conditions. We have more male than female in our respondents, and we have average of adult respondents 32 and 16.5 for the youth smokers, 16.3 for the youth non-smokers. All right, to answer our first aim, we just basically do means differences on the effectiveness rating and the believability rating. So these are, on the right side, these are the questions that we use to produce the perceived effectiveness rating. We have 4 questions, while for the believability, we only have 1 question. And we can see that the effectiveness of pictorial warnings are so much higher than the text-only warning. And these patterns also goes the same for the believability ratings. And based on this, we try to give a ranking by health topics on each image that we test in the study. The 4 top images, the 4 highest ranked images are gruesome images. We can see that the mouth cancer have the highest rating for effectiveness, which is 8.91, followed by the throat cancer, and then the lung cancer and the heart disease. These 4 are the gruesome images. The mouth cancer is pretty out of our prediction, because during our effort to find the victims of the real victim for mouth cancer because of smoking, we found it very hard. We tried to contact most hospitals in Indonesia to get the victims of mouth cancer, but we always get a similar problem that we rarely find the mouth cancer victims in Indonesia. So this is another question that we should be raised. But I don't know why they just put the mouth cancer as the highest rating. So I see there is a gap between the perception and the reality in this study. And then the last 4 rankings, we have human suffering image, addiction, death, and secondhand smoking. And we have 1 symbolic image, which is the importance. This is also out of our prediction, because we thought that the importance will be higher because we have so much male smokers. But it turns out it was the last. It was not really the most effective image. So we dig deeper for the image types versus text-only warnings in terms of the gruesome, suffering, and symbolic. As we can see here that the gruesome image have the highest rating compared to the suffering and symbolic. Although all 3 types are significantly different than the text-only warnings, but still the gruesome images are the highest rank. So we try to confirm this finding with doing linear mixed effects models, and then we can see here that the findings support our previous findings, which says that text only, which is the lowest rated, followed by symbolic human suffering, and the gruesome is the highest rating in terms of effectiveness rating or even in the believability ratings. So going on to the second findings of our study, which will be the main course of this presentation, for whom were testimonials most effective. We started with doing means differences on the rating of effectiveness. So here we see that there is no significant, although for the adult smokers, we see that the red one is the testimonial condition. We see that it is higher than the didactic, but there is no significant differences. And for the youth, both youth smokers and youth non-smokers, the didactic texts are getting the highest rating than the testimonial, and the differences are significant. This basically just give us a clue that for adult smokers, it doesn't really have difference to use testimonial or didactic. But for if we aim for youth, we should use didactic. And this also raised another question: why would youth rate the didactic higher than the testimonial? And in terms of the believability rating, we also find similar patterns, except for the adult smoker, the differences in testimonial text is significant. So in terms of believability, adult smokers see testimonial text significantly more believable than the didactic text. While for youth, the didactic text is still superior over the testimonial text. If we see by the image types, we can see how that patterns goes the same for adults and still differently, still going opposite way for youth. So no matter what the image types, but we can see that on the gruesome image, the ratings are higher, and we can say that in the gruesome image, this kind of give a clue for the interaction effects. And we try to look at the believability ratings, and then here we see on the gruesome image as well that the adult smokers rated testimonial as more significant, as more significantly effective than the didactic text. And oppositely for the youth, they rate the didactic text as significantly more believable than the testimonial text. This is also suggests for the interaction effect. So we try to do the interaction effect for all types of images. However, we only found the interaction effect as significant on the gruesome image, and those apply for both the effectiveness ratings and the believability ratings. So we can see on the effectiveness rating, the difference between the rating on the effectiveness among adults is pretty not much wide compared to the believability ratings. So the use of testimonial and didactic, it depends on whether the target is youth or the adult smokers. So what we can conclude from this study is first that we confirm findings from previous studies about the superior effects of pictorial warnings compared to the text-only warnings. And we also provide support for the gruesome image as the most effective, followed by the human suffering, symbolic, and the text-only. In terms of the, oops, I'm sorry. In terms of the text style, we found that the testimonial on human suffering and gruesome image is significantly more believable than didactic for adult smoker, but not significantly more effective. And for the youth, we found that didactic is significantly more effective and believable than the testimonial crossover image types. So, but we don't want to be too much confident with our findings because we must acknowledge the limitation of our study. We have convenient sampling which will limit the generalizability, although we try to reduce this burden with applying the intercept technique during the approach of our respondent. Maybe you ever heard about the third-person approach. Basically, our interviewers only approach the third person who passed on the certain spot that we already decided, or the third person that they approach in public places. And we also have, our design is a cross-sectional one-time point and a forced exposure. It is much more different than the real life, when you found the warnings on the real cigarette packs. So we don't want to mislead you into that direction. And as for the suggestion for future research, we have to improve our study in terms of to compare the previous regulation with the current regulation. We can do the repeated cross-sectional. As I said, that we have been able to do our study just before the implementation. We have been able to collect a question about the perception of the text-only warning before they get exposed to the warning image. And if we can do similar study, similar data collection in the near future, we can say that this is a natural experiment because they just exposed to the real life of the cigarette packs. And we can also do, with this repeated cross-sectional, we can also assess if there is a wear-out effects, because we already have data for the pictorial warnings, for the 5 pictorial warnings that currently be implemented. If we can compare the ratings with the future study, we can see if there is changes and whether the changes is reduced and whether the changes different across all image types. And we can also do experimental design because we saw that there are fear appeal strategy, there are gruesome images are on the top list of our findings. We can enhance this the use of fear appeal strategy with probably implemented or following the extended parallel processing model. We are now doing a qualitative study to adapt this extended parallel processing model to see whether it is applicable, whether the constructs are applicable in Indonesia context. And once we have the findings, we can start to develop the study design. And while doing that development of study design, we can also think about improving the testimonial appearance in the pictorial warnings, saying that we can maybe combine it with the behavioral cues, or maybe combine it with the efficacy message, and see whether they will increase the effectiveness of the testimonial message. And for that, we need more studies. And that's all that I can present right now. Thank you. Terima kasih. we still have time for questions.
Yeah.
Please, if you have any further question, or don't hesitate to contact my email if you are interested to do this kind of study.
Maybe I'll start.
Alright.
So one of your two main outcome measures was this effectiveness measure, and I was surprised you didn't raise it in the limitations because we find that also with mass media campaigns that sometimes what people say aren't going to be as effective, that you find afterwards in better design real life studies that they are actually more effective. So do you want to talk about that measure and maybe how much, what some of the limitations of the effectiveness measure might be?
Yes, this is actually a good comment, and I should add that in the limitation of study as part of our cross-sectional one-time design, and this effectiveness rating is a perception, it's not the real effect. So in the follow-up study, we need to do the real effects, and it's a little bit hard for us to do the real effect of the warning labels because we don't have some kind of behavioral cues like quit lines. So we don't know how to assess. If we have a quit line in there, we can directly relate it with the numbers of quit lines, like the previous study that have been done about these warning labels. Thanks for that comment. All right.
So, in the difference in the presumed effectiveness of the testimonial between young people and adults, I was wondering, is there any country that has testimonial warnings where you're modeling young people, where there's actually? So I was wondering if the disconnect between who's being modeled there and the young people might be a factor. And I just wondered if anybody has any rotation about the impacts of not smoking on exposed children, but actually the impacts for young people in the immediate sense.
There is a very nice suggestion for follow-up studies that we can play a little bit more with the data and just select the specific image and compare them and see the differences between the testimonial and didactic. But in terms of the studies around the testimonial and didactic, I only found 2 studies, and they don't really focusing on the differences. While in our study, we have all the images. We have like for one health topic, we have 5 images for the didactic and 5 images for the testimonial. In the previous study, they have in each health topic they have 5 images, and one of them is testimonial. So we cannot clearly state it that this affects due because of the testimonial, because they don't compare it even in a controlled manner.
Just maybe worth following up with young people if it's that they're turned off by testimonials or they're turned off about testimonials for grown-ups.
Okay. All right. Yeah, thank you.
I'm really glad that you mentioned about EPPM at the end, because coming from Indonesia, living with smokers, really, my dad is heavy smokers. I really see that perhaps perceived susceptibility is really important, because I feel that they know that there is a risk for this, but they don't really think they're susceptible to that risk. And that's something that I think may also explain the gap between, as you mentioned, the reality with the perceptions of not cancer. Why? Because it only looks scary, but they don't really feel susceptible to that. And really hope that there will be further experiments with incorporating EPPM.
Yeah, I agree with that. With using a EPPM, we can actually see whether the fear appeal strategy backfire or not. And because in our first round of pictorial warnings, we don't have any efficacy message, we don't have any behavioral cues. We just put the smokers as the victims, and we just blame the victims for what they're doing, so they might be backfire with using it.
Dien, did you notice any differences between warnings that were very specific to the individual versus the impacts that smoking has on the collective? So in some Asian countries, some of the strategies have been to have warning labels that don't just talk about the personal effects, but how it affects. So you had some on the effects on the family and things like that. Were there any trends with that?
Yeah, we did collect the data, and we did have images for to do that kind of analysis, but we haven't done that. So there will be a nice way to follow up the study. Thank you.
Thank you for that presentation. It was really interesting. I was wondering if you have looked at how the results of your study compare with some evaluations of mass media campaigns that might look at didactic versus testimonials, and then also sort of building on the discussion about the disparity between adult and youth. If you considered, like, in addition to maybe modeling like youth on the warnings, also sort of like communications or warnings that might deviate from the health topic a little bit. Like, I know a lot of mass media recently in tobacco control has focused sort of on youth empowerment to avoid smoking rather than sort of like the cautionary warning angle. So I wonder if you think that has any place in packaging.
Yeah, we have I need to confirm the question. When you're talking about the mass media campaign, is that the tobacco advertisement or the anti-smoking? Or the tobacco control mass media campaign? Okay. We just had one mass media campaign for the anti-smoking, and it was released a few months later after the implementation of this warning. But we haven't got a chance to collect the data to see whether this is have correlation or strengthen the effects of the pictorial warnings. But that will be a good way to look at the combination of this strategy. Thank you. Okay.
Maybe a step back. I was wondering if you could talk about how you got the pictorial labels in the first place, considering all the other things that you don't have, and then maybe you don't have here, like the politics maybe behind getting the government to mandate pictorial warning.
There will be a long story, but but
We can talk about it over lunch.
as I said earlier, previously, or maybe up to now, the policy making in Indonesia is basically a political decision. It depends on who is in power. It's more depends on who is in power. And when we first deliver our result to the Ministry of Health, we were like, we just the first to submit evidence, and they were really appreciate our findings because some of our findings are really supporting with the decision to use the graphic image. So we need more studies to help Ministry of Health, and they look forward for that. Maybe in the future we will have more evidence-based policy initiative in our country. And hopefully we will working toward that way. Thank you. So I think that will be our end, and thank you very much, and I'll see you soon.